talk first.
Thank you very much. I'll be giving my talk on laser cataract surgery for posterior polar cataract. Hello, yeah, sorry. I'll be giving my talk on laser cataract surgery for posterior polar cataract. As you all know that posterior polar cataract is something that is always an issue for the surgeon. And whenever you're looking at a posterior polar cataract, the posterior polar cataract has the possibility of having a pre-existing posterior capsular defect. And if you do not recognize this, which people did not recognize in the earlier phases, you could have a nuclear drop in these particular cases. There is, as I told you, when you are doing hydrodissection, that can cause a hydraulic rupture of the posterior capsule. Here I am going to highlight the use of a femtolaser. Not all of us would be having a femtolaser, but here I would say this is one of the indications for doing a femtolaser assisted cataract surgery when you are having dealing with a posterior polar cataract. So a femtolaser assisted pneumodissection that happens precludes the use of doing a hydrodissection in these cases. So therefore the rotation and gentleness of the whole procedure that gives you a very high safety cushion. The nuclear disassembly and capsulorhexis having been done, you can also make concentric rings. They make it much simpler for the nuclear disassembly. Now, whether you are doing with phaco or you are doing with the femtolaser, the points that have to be kept in mind are that it should be a closed stable chamber. The fluidics in a polar cataract needs to be less. They pretty light color. Yes. Using the anterior segment OCT which is there, that helps in delineating whether the polar cataract where it is or not. And careful hydro procedures, not a hydro dissection but a hydro delineation, and using of an epinuclear cushion that you have in a polar cataract. Now the anterior segment OCT helps you see before you enter. So what I am wanting to show you here is that you see this area. This is a posterior polar cataract which can easily be seen, and you can see that the capsule is discontinuous here. So this means that pre-operatively we are able to say that this is going to have a pre-existing rent which is there. Now you can see in this particular case, if you see here, what we do is that on the femtolaser system, we are upping these bubbles. So what we are doing here is that the nuclear disassembly is leaving behind an epinuclear cushion. So you have actually visualized as to where the posterior polar defect is, and you have raised the area where the nuclear disassembly has to be done. And this is what I just showed you, was that this is a normal. This you can see the defect, and you can see we are raising with the bubbles here, so that the nuclear disassembly is above that. So various people have reported, I won't go into the detail, they have talked about pre-operative evaluation, but we were the first to say that the AIOCMTC that can be used within the catalyst system or within any flag system, that will give you an easy
FEMT was a great help to prevent nucleus drop, and pneumodissection really helped. We could do the case without hydrodissection and hydrodelineation. It's an excellent presentation, sir. Any question from the audience?
To what level of subluxation you can use femtosol?
Subluxation is
I'm just asking you. To what
yeah,
level
so
of
basically you can use it even if you have until of course it is vertically dangling like this. In subluxation, the biggest advantage is that it can cut through vitreous. Even if the vitreous is coming through, you don't need a counter traction which you need in the other cases for doing a capsulolysis because it cuts through. So you can have even 180 degree subluxation and you can do that. Nuclear disassembly has happened. There are separate videos that I have for that, but subluxation, if you are not able to focus it, that is the biggest stop sign that you can't really do it. But even if there is a subluxation vitreous is coming through, you just increase the energy and you are able to cut it through that. Subluxation 180 degrees after that. Okay. Thank you.
Sudipta has a presentation in another hall. So, Sudipta, you can present your talk.
Good morning. It's indeed an honor to be here today, and just a second, it's not showing, please. One sec. Wait. Respected chairpersons and my dear friends, the topic, and thank you very much for allowing me to speak before my time. The topic on which I'm going to talk today is just a second, where is it? Refractive surprises, tips and tricks of management. There's a bit of audio. Can you please allow the audio to play? Just keep it low. So I have no financial interest in anything that I'm going to talk about today. Now previously it was to restore good vision. That was all for cataract surgery when we were doing cataract surgery. That's removing the obstruction that was there with or without glasses to see well. But now we need multitasking, looking at all distances, intermediate, near, or for distance. The lifestyle IOLs are there. People need to see at a time at all distances, and the dilemmas are that there are Google teachers, people know about the newer IOLs, they ask for it. So we need to spare more time with them, choose the best IOL that suits them. And even after a good surgery, we may have refractive outcomes which are surprising, either for the clarity of vision, distance or near, or due to the other reasons like dry eye, PCO, macular pathology. I'll be discussing some cases about like this. Case 1, which was a very dissatisfied patient which wanted IOL exchange. This was because he had minus 2.5 residual astigmatism, and when we looked into the pre-op biometry, found he already had pre-op astigmatism of minus 2.25 and 2.5 in either eye, left eye, already had. So now my task was to deconvince him for IOL exchange, which is never a very good procedure. Convince him and send him for refractive surgery in the left eye, or do a right eye surgery. I did a right eye surgery. He got a Plano 6.9 with a toric IOL plus 3 with add, and left eye I could convince him for a spec power, and we sent to the retina colleague. But not always are we so happy, especially with multifocal surprises, dysphotopsia. So the options, what are they? Laser, IOL exchange, or a add-on IOL. Now IOL exchange, where we can't do anything else, I think there we choose for it. If for example there is opacified IOL and the patient's vision drops, or there is some other reason. But this is a very tricky technique, because if it is very well adherent, we may lose the PC. So it's better to lift the IOL from the junction of the optic haptic. If you can move it, slowly dial one at a time from the out of the bag, and then after forming a good AC, you can take out one of the haptics from the main wound and then cut the IOL either through and through, full thickness, totally or halfway, and then slowly dial it out to keep the wound, slightly stretching the wound, not enlarging it. Once you dial on one side, and then you can rotate it on the other side and take it out. Thanks to some of my mentors, this procedure was taught by them, and then you get a good AC depth. And if you are lucky enough and have a good bag, you can reinsert the same type of IOL. Just look, we have these complications, the iris chafing, or sometimes trauma to other parts. Now, biometry in these cases are usually done by Barrett, IOL master. You can also do with ultrasound. You can use the immersion method to find the calculation. The next method is the laser, PRK or LASIK. Photorefractive procedures are very good when you have higher order aberrations, but keep an eye for OSD, ocular surface disorders. They are very effective for elimination of post-operative surprises, and especially with femto laser correction, LASIK, it is much better because this is a very good procedure and best suited for myopic surprises, where we actually create a flap with a hinge and with the tracker system. This is the Zeiss refractive suit. You can actually femto out the flap and use excimer laser to do the ablation and do as much correction as you feed in the machine. And the procedure is very neat and clean, and the patient usually recovers very well. Of course, you have to keep an eye over the ocular surface, as I said, and it is very happy procedure. Sometimes you have some special scenario like this, where you have very high myopics with IOLs which have to be tailor-made, a myopic IOL, and you never know what you're exactly inserting, what you're actually going to do, but then you have to do. And you have huge refractive surprises. This was a hyperopic surprise. So here in this case, the patient was very highly myopic. So we did not want this patient to end up in hypermetropia, and I had a choice of IOL exchange or piggyback. Piggyback IOLs are not easily available, neither are these sulcus IOLs. Piggyback IOL, you actually have to put a hydrophilic over silicon or silicon over hydrophobic. This was a add-on, but sulcus fixated IOL and more like a phakic IOL. It only that it was inserted in a eye which already had a PC IOL, and the design of the lens is different from that of a phakic IOL. But if you have a good AC depth and well done, well-centered PC IOL, this was in topical, by the way. It is better to do it. I learned with time that it's better to do it with injection. I mean peribulbar, it stabilizes and reduces less pain. You have to have a very stable anterior chamber, good viscoelastics guiding your lens. This lens, tumbling of this lens is really difficult. So it's better to guide the lens, go slow, look out for the proper notch if it is well placed, tucking the IOL, and be very careful not to put it in the bag, because this is for the sulcus, and sometimes you may end up while tucking, it's very flexible, and it goes in the bag itself, so then it's a big problem again. It's very difficult to take it out because the bag cannot tolerate 2 IOLs at a time, and especially a fibrous bag. This is fibrous because I waited for pretty long time to find out the change of refractive error, and until it's stabilized, we did not do the case. It's better to do a peripheral alectomy since you have 2 IOLs, and do a thorough AC wash in between the lenses. Their viscoelastics, they create problem. And this patient ended up quite well with a good result, AC depth and good vision. So these are the take-home messages. Customize each case and choose for the need of the patient. Spend more chair time when you have refractive surprises. Choose the correct procedure. Choose the best method, judging the pros and cons. And careful refractive estimation. Please wait for the refractive error to stabilize the spherical equivalent. Look out for factors like OSD, PCO, astigmatism, gutta. Counseling is very important. Sometimes simple counseling with little bit of here and there is always good, and surprises always help you learn. Thank you for patient hearing.
Sudhita, your IOL exchange case had opaque IOL, isn't it?
Yeah, this case was opaque IOL, but this is for the sake of mentioning the IOL exchange. But usually we do in clear lenses also if required.
Very nice presentation.
Thank you so much. Okay. Thank you very much.
Next presenter is Dr. Chitra Mutivan.
Long and short story. Iris clip iris.
Iris clip IO is the long and the short story.
Very good morning to the moderators on the dais and friends in the audience. So my job the next few minutes is to talk to you all about the iris clip lens or the retrocapillary iris fixation IOLs. Now, why was it that this evolved and what is it had to offer when there was an inadequate capsular support? The ACIOs were in a time when we were still acquiring our surgical progress, and probably on hindsight, if you look back, if our surgeries had been perfectly done, probably the ACIOs would have also a place in the armamentarium as a secondary IOL of choice. But the critical issue for an anterior chamber IOL is the sizing of the IOL, which is what is the defining factor, and because it failed was because it was closer to the endothelium. The iris clip lenses came as a huge advantage. One, surgically it is very easy to learn, and it is also placed behind the iris and well away from the endothelium. Only thing, you need to have an iris support. So suppose it's a case of an essential iris atrophy, or it's a case of an aniridia, or it's a neovascularization on the iris, or it's a case of uveitis. These are clear-cut situations when you would not choose an iris clip IO as a secondary capsular support, eyes without a capsular support. Of course, SFIO have their own standing today and with a variety of lenses which have come across, but then it is definitely needs a little more of a learning curve. So the procedure for an iris clip lens is fixing the lens to the back of the iris and requires sufficient iris tissue. The lens, it comes at an optic diameter of 5 mm, overall length of 8.5 mm, and it has oval haptics, and you can see it has pincers at the end of the haptic, which is how it grips the iris. And the A constant we need to remember is 117.2, and different people in markets come with slightly differing but nearly the same IOL part. And how it evolved, it came from a plano-convex to biconvex to concavo-convex lenses as they offer. But what we need to remember, supposing the patient was for a 3-piece IOL in the bag, assuming it was 118.4, and then he has a surgical complication and you want to place an iris clip IOL, it's 117.2. So you need to subtract that 1.2 and then subtract it. Supposing the IOL bar was to be 24, it needs to be 22.8. So that is how you would have to calculate your IOL bar. The instrumentation is so basic and simple. You just need forceps to stabilize the IOL as you are inserting it. You need to make your paracentesis with your sideboard blades, and then you need to just have one simple dialing hook to enclavate the iris, or even an ordinary syringe with a cannula would do. Now, as far as the basic surgery is concerned, essentially you make your conjunctival periphery, and supposing it's a case of a situation like this as a very subluxated cataract where the primary plan of action is then it's best to make a scleral tunnel and not enlarge the corneal incision, because you need to, from a 2.4 you would have to enlarge it to insert a 5 mm optic of the IOL. You would not make a superior tunnel if you think this patient might need a glaucoma surgery later. You should make a thick enough flap, but not too thick that you have a premature entry, or not too thick that you have a buttonholing. Supposing you want to do a temporal corneal incision, then what you would need to do is, if you have already made a limbal incision, you could make your side cuts and then do it, or you could plan a temporal clear corneal in a different plane. Now, as far as anterior vitrectomy is concerned, before you are going to plant your IOL, you need to do a good anterior vitrectomy. You inject tricot to see whether there is no vitreous strands which are there, and definitely top it up with a gap PI. Although, if you have done a good vitrectomy, there are some who would question what is the role of a gap PI. You need to constrict the pupil with pilocarpine, and after you have placed your, as I am going to show you here, you make your side ports at 3 o'clock and 9 o'clock if it's a superior incision, if it's a temporal incision, 12 o'clock and 6 o'clock. And after you make your side port incision, what you do is through the main port, you with the enclavation forces, you hold your optic and then go through the side port and just a dialer, push the iris so that it is caught by the pincers of the haptic behind the IOL and stabilize the IOL and repeat the same process, inject viscoelastic so that you have created space, then go in and stabilize the optic and go through the other side port and then just nudging the iris tissue so that and hold the optic close to the iris from posteriorly. Now what you need to be careful is you use a symmetric amount of iris should have been tucked in both, and that pressure, counter pressure you will learn by experience, and if too little is got, you might get an asymmetric like an oval pupil kind of appearance. You need to do an adequate visco wash, which is most important, and sometimes you could even, if the superior tunnel, you can go to the side port and nudge the iris out so that you are able to pull it out and do a PI. Post-operatively enough anti-inflammatory is needed. If the iris tissue is inadequate, as it was in this case, the primary surgeon had made a large tear. As you can see, it comes up. So it is still possible because on either side there is enough iris tissue. You could go ahead and insert a lens and clip it. You can even obliquely place the iris clip lens. It's not necessary it's only horizontal or vertical. As long as there's enough iris tissue, you could enclavate it. This is a very large eye with large pupil or chromatic mydriasis was there. There is always a chance, ease for you to do a pupilloplasty, complete your pupilloplasty, and then you could just nudging an iris clip lens, and in macroseconds, these are all practically unedited videos. You could just place your, once you have downsize the pupil size, you could go ahead and place your iris clip lens and enclavate it, ensuring it is symmetrically positioned. And this is how the eye looked following the surgery. Now this was a completely messed up pseudo-phakic Buddhist keratopathy, and all you have to do is scrape the entire unhealthy epithelium, and after you have debrided it, you can, I wish I could fast forward it, you could place your iris clip lens, and once you place the iris clip lens, you could do your DSEC procedure and insert the DSEC clamp and then complete your case with great ease. Now what happens if the haptic disinclavates? Now if the haptic were to disinclavate, as is going to be shown to you, when you go back, you should ensure that the vitrectomy is done adequately if there is any issue there, and after doing the vitrectomy you will myose your pupil and then hold the optics and stabilize it and re-enclavate it. But at the site of during re-enclavation, you should also find out what could have gone wrong. Is the haptic broken, or is the iris tissue torn in that area? Should you re-enclavate in the same place, or should you re-enclavate somewhere else? Are some decisions to be taken. Now this was again another case where it had disinclavation is done. Sometimes when you are re-enclavating, you realize that the other side is also not enclavated well. So you should disinclavate and re-enclavate. For that, you need to just hold the optic of the iris clip and push it posteriorly, and with the spatula from the other side port, just lift up the tissue. Sometimes you can easily do it from the anterior approach, but sometimes you may have to nudge the iris out by going behind the IOL. So essentially, all these small tricks are hardly ever necessary once you've got the knack of doing the procedure. It can be done under topical anesthesia or a subtenon rarely. And definitely you get a deep anterior chamber, you are quite gentle with the endothelium, there's no sizing issues, very short learning curve, and some minimal manipulation of the vitreous is all that is needed. Thank you very much.
Excellent presentation, ma'am. You have demonstrated iris fluorolysis in all situations. Next is intumescent white cataract. Keep all armamentarium ready. Dr. Bharti Kashyap. Welcome.
Well, good morning all. First of all, I would like to thank the AIOS Scientific Committee for giving me this opportunity. On kar dijiye. This is the case of intumescent white cataract, for which we have to keep all armamentarium ready, like a big white shark in the ocean, which is difficult to conquer. It is not only the Argentinian flag sign associated with this, but there were some unexpected surprises which were encountered in this case. With the help of image guided system, we gave incision, and now we are doing punctorexis in quadrant mode, setting on the Centurion vision system with the balance tip. Once few shots are given in the quadrant mode, the lens is debulked, the anterior capsule becomes quite flat, and rexis is started. You can see the anterior capsule is quite flat, and rexis is going to be completed in a very predictable manner. After the rexis has been completed, the nucleotomy is being done on the Centurion vision system with the balance tip. In this case, you can see the nucleus is very hard, and direct chop method is used, and nucleotomy is proceeding in a predictable manner, and lens pieces are emulsified easily. But oh my god, what am I seeing? I thought the surgery is now getting over and I am done. But I can still see the white shark deep within. There is a thick posterior capsular plaque centrally and a thickened central posterior capsule as well. These primary posterior capsular plaques are mostly seen in diabetic patients, in mature cataracts and in pediatric cataracts, and it poses a special challenge to the cataract surgeon, and it can be highly adherent to the posterior capsule and may lead to posterior capsule rupture while attempting to remove it. YAG laser at a later date has a risk of retinal detachment and pitting of IOL. Some posterior capsular plaques are so thick and adherent that they are not amenable to YAG laser or by retinal end grasping forceps, which is used by the retinal surgeons to peel epiretinal membrane. In this case, there is a central posterior thickened posterior capsule as well as the adherent plaque. So I have decided first to implant the monofocal Clarion foldable IOL. Side port is used to make a pars plana route, and then we are using vitrectomy probe through pars plana route, which where AC is maintained through the irrigation via anterior probe route. This central plaque is being removed by vitrectomy probe, and you can see it is removed very easily. So cataract surgeons are really in need of variety of techniques in the armamentarium to deal with these posterior capsular plaques. This handy technique can be used in the arsenal of the anterior segment surgeon for getting rid of the posterior capsular plaque, and it is very easy for any anterior segment surgeon to go through the side port to the pars plana route and do a little of vitrectomy and remove it. With the vitrectomy probe you can do it. Thank you.
Very nice presentation. Thank you very much. Next. Any question from the audience? Is Dr. Amia Kulkarni here? Dr. Amia Kulkarni? Not here. So, if there are no questions, ma'am.
Dr. Chitra, can I ask one question for Dr.
Sure.
Chitra here? Sorry to call you back here. I think that was a fantastic presentation on retro-iris claw fixation. 2 points is in what type of irises would you not want to do them, and if you have to disenclave, suppose their enclavation has not been symmetrical, and if you have to disenclave, any tips on those please?
Yeah, if irises, if it is torn or if it is very and there's a large PI in that area and all, you will not do it. And of course, if there's an inflamed iris, NVI and all that, you can't do it. UVI TKI, you can't do it. When you want to disenclavate the iris, if the iris is actually held there and it's a little asymmetric, I actually will, on the table when I'm doing, I would disenclavate and re-enclavate. But later, unless the patient is disturbed, I would not go to disenclavate it. But when I have gone, and anyway one haptic is disenclavated already and I'm enclavating it, then I see the other one is not so effective as the only time when I do. Because whenever you disenclavate and re-enclavate, there is often a hole which happens in the iris. And you find that, and if it is sort of really stuck, then you have to actually change your side. Yes. So somehow with the minuscule tissue it gets held. So if you have to disenclavate it, you go to your main port and grip the optic centrally and go to the side port from the opposite side and just go behind the iris and just lift it up. You can do it, or you could even go and really push it down also. It gets disenclavated. I think I've not been able to explain it too well, but it is easier to enclavate than to disenclavate.
Yes, I think that was the message which I was trying to take across, that disenclavation always causes more iris trauma. So it's always it's advisable that you think well where you're going to enclave, and I think there's a learning curve to it, and then once you really do it, then don't go back to undo it, because that might be more traumatic.
I would like to add something about intumescent cataract and hypermature Morgagnonian cataract. Whenever you make a puncture at the center in intumescent cataracts, you get oily fluid or some water mixed cortex coming out. And whenever you make a puncture in Morgagnonian cataracts, milky fluid comes out. In Morgagnonian cataracts, you don't need to do a mini rhexis. You can aspirate and you can do an optimum size rhexis at one go. But in intumescent cataract, it is always safer to do a small rhexis first, aspirate some cortex, make a nick at the margin of the mini rhexis, and then do optimum size rhexis. So here we conclude our session. Thank you very much for attending.